what are they engaged in? What kinds of medications are they on right now? Do they have any other signs of ischemic heart disease of some sort? So I'm looking at the rest of my signs and symptoms to determine, do I have a good cause to a bad rhythm, or do I have a bad cause to a bad rhythm? Then the decision-making process, which we're not at yet, but we're getting there this term, is now I have this rhythm. Do I have to fix the rhythm in order to fix their cause, or do I have to fix their cause and that will correct the rhythm? We're not there yet, but we're getting there. Does that make sense?
Yeah.
You're asking the right questions. You don't have the answers yet, but we're gonna get there. We're gonna get you those answers. But those are the questions that you need to be asking. Do you understand what he's asking?
Yeah.
On these? Right?
Can I fix it or not?
And your decisions are, do I treat my rhythm, or do I treat my patient's signs and symptoms? And either the treatment of the rhythm will fix their signs and symptoms, or the fixing of their signs and symptoms will fix the rhythm. And your job is to figure out which way you need to go on that.
Bless you.
And we're gonna start that process today.
Dun, dun, dun.
Good?
It's exciting.
Questions so far?
Can I ask a question about
You can
treatment
ask
for
any
that?
question you want.
So
Just
if
don't let it be
it,
done.
what?
Just don't let it be done. I'm just kidding. Go ahead.
So if this rhythm was caused by ischemia, where there's a lack of blood flow getting to the AV node to give it the oxygen for the ATPase pump to work, would we see, I guess if it's just going to the AV node, we wouldn't see ST elevation, because that would be in the ventricle, right? That would be, if there's ischemia in the AV node, would we see the ischemia in the ventricle with ST
It
elevation?
depends on what downstream blockages, what downstream effects are happening by
Okay.
that blockage of blood flow.
And then if there's
So
a,
blood flow that goes to the AV node often goes to other portions of the heart too.
uh-huh,
So it completely depends on what's happening downstream.
okay. And then if we had that ischemia, would we have the ischemic signs and symptoms with chest pain along with that?
Yeah, quite possibly.
And so then
so
when we,
what you're seeing here is determined by what's happening here,
uh-huh,
for sure, right? So whether or not, if the reason for this blockage isn't related to ischemia to the ventricles, then you won't see a change in the ST segment, because that is completely based on what's happening to the ventricles. If what's happening here is affecting the heart globally, and you will see, and there is ischemia to the ventricles, then you will see a change in that ST elevation as well. Which is why you often see an associated change in your ST segment in a second-degree heart block as well.
Because
Right.
blood flow.
So-
Because you're often having blood flow problems to the heart that is affecting the heart more globally.
so then are we thinking nitro to help with this problem?
Yeah, so then that's the decision you have to make, right? Is my ischemia that's happening here what's causing this rhythm? And most of the time in a type 2 heart block, that is the case, right? Or is there something else that's happening that's causing my rhythm that I need to fix first?
Well, and you'd have to figure out if it's right or left-sided, right?
Before you decide nitro?
Yeah.
You're cautious on the right side with nitro, but that doesn't mean you're gonna not give it.
Means you might get an IV.
But yes, those are things that you're making determinations on, yeah. Right? What would I see if my SA node is working and my AV node is working and everything downstream to them is working? So my SA node through the atria, all of that depolarization is working fine. And my AV node down through the ventricles, that's all working fine. But for some reason, my depolarization process through the atria is not translating into the AV node.
First degree.
I just heard two different heart blocks.
Third degree.
Third degree, wasn't it?
Third.
I think what he's saying is the SA.
Probably
Oh, third degree is two different hearts.
Yeah.
Mhm.
What's first degree?
Delay.
elongated PR.
Delay.
It's the winky block without a drop.
Well, it's the
No,
same.
It's not elongating, it's just elongating.
First degree is just
Oh,
that
yeah,
greater
yeah,
than
yeah.
.20.
Thanks.
So what I said is I've
I
got
have a
my
first degree
SA
while
node
brain
is firing, and it is sending its signal down through the atria, and that is all working fine.
That's my third.
My AV node is working fine and is firing and sending the signal down to the ventricles, that's working fine. But something is happening such that what the depolarization process in the atria is not translating to the depolarization that's happening in the AV node.
QRS is refined.
What would I see?
Two different hearts.
Dissociation between the P waves and the QRS.
So what does that mean?
So it's the third degree heart block.
What does that mean? What do I see?
You see your P's plug out in time, and you see your QRS's plug out in time, but they would not be associated.
And what is not being associated with?
The P would not cause the QRS.
And so therefore, what would my rates be?
Two separate rates.
Yeah.
You would have
Understand
a,
what's being expressed?
Yep.
So I will have P waves that are plugging along, and when I map them out, when I calibrate them out, they'll all, my P to Ps will all match. I'll calibrate out my R to Rs, and they'll all match, but my P to Ps won't match my R to Rs. And I clearly don't see an association between the P wave causing the QRS at any point in time. Okay? And that's my complete harmony.
That's atrium and ventricles each having separate pacemakers.
Correct. My pacemaker in the atria is still my SA node. My pacemaker in the ventricles is still the AV node, exactly like it's supposed to be. But the SA node isn't the overall pacemaker, because it's not translating everything to the AV node. The AV node's on its own. Right? In which case I have a blockage that shows two completely different associations between the two. And when I look at my rhythm regularity, what would it be?
It's gonna be regular.
It's going to be regular.
Ventricles.
But your ventricular rate is gonna be
Probably
20 to 40.
I'll have a different rate, that is correct.
Is
They will
there
not match.
any reason with a third degree heart block that your ventricles would be firing faster than your atria?
Sure, absolutely, because what could I have in the ventricles that would cause it to fire fast? Yeah, I could have VTAC, for example.
With, okay.
Yeah, when you look at your VTACs, it's not uncommon for you to see P waves mixed into your VTAC QRSs as well as it's going along. That's not uncommon. Because you might have
Would that be
you
hard to-
might have a disassociation there.
Would that be easy to see
Depending on
on?
the rate.
Once you print it out, you'll start to notice it.
Okay.
So you would still call that regular with the third degree heart block just because they are regular to each other?
Yeah.
Even though overall it's irregular because it's not together?
You, typically when so that's a really good question. I would need you to define it. When we initially talked about regularity, we're really talking about R to Rs.
Okay.
That's the first thing that we look at. It's gone. It's so disheartening
Isn't it?
to have a sneeze that doesn't happen. So you would be fine calling it regular or irregularly regular. Either one of those would be acceptable as long as you were able to define why it is that you're calling it that.
Okay.
Good? Questions? Okay, what would happen, what would I see if my atria were affected in some fashion by a drug that wiped them out for a period of time? But my AV node and the ventricles were not affected by that same drug. My AV node and my ventricles were not affected, but my SA node, my atrial pathways, and my atrial cells were
Like
affected.
a run-on of junction.
Completely.
Or let me change that. My SA node and my atrial pathways were affected. The contractile cells in the atria were not. But my pathways and my SA nodes were affected. My AV node and my ventricles were not affected at all. What are some options that I would see?
Junctional rhythm,
What would I see?
you would see an inverted P with a shortened
Or no P wave.
Or
PRI.
Okay,
Or no P wave.
or no P wave? Because why?
It's in the QRS.
Because it may be hidden. What else could I see? I might see an ectopic atrial rhythm if something in the atria took over. Yeah. What else could I see?
See ventricle.
I could.
So is,
And then what would happen after that? Drugs are still affecting the atria. Still
So then-
affecting the SA node and the autonomic cells in the atria.
then it'd go back to being a junctional rhythm.
Okay. So what else could I see in that junctional rhythm? So you talked about a
Multi-
inverted P wave. You talked about no P wave. What else could I see?
multifocal atrial
So,
If you,
wandering. Yeah, that's what I
If you,
meant.
A walk.
if you can get a P wave in
Atrial
that case
pacemaker.
where the conduction system is down, then they're gonna be
and a map,
low.
what difference between a WAP and a map is 100?
If it's,
What
I
about
mean,
Why would it be
AFib?
low?
Did you see AFib?
if the,
What?
Did you see AFib?
because the contractions is not all being, all at
That
once.
is
I guess it could be
Someplace
AFib.
else in, other than the.
That's a good point.
Do the atria have
Because
to
it would be potentially
It's
random.
AFib or A flutter.
How does the,
Yeah,
how
it
does
could be
the
A flutter,
signal normally go to the
because
atria?
it gets in that loop.
But is it going through the pathways? Because it
Does
they
A
flutter
flutter
go through
go through the
pathways.
pathways?
Atrial
Yeah,
contract
because
cells.
remember it's a stop in the pathway.
Oh,
How
yeah.
is that
Yeah.
different?
So it'd have to be AFib.
AFib would be the only option.
So it would not
You
be
would-
flutter.
you may-
Correct.
No, because A flutter, like you said,
Goes to
A-
the-
through the
where it's
pathways.
coming from,
A flutter goes through the pathways.
pacemaking cells sending
That
it out,
makes sense.
going away or towards the lead or across the lead.
It's coming from the AV node.
Ding, 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 ding.
So how would that change?
If it's coming from the AV node, then we would have a inverted.
Okay,
But if it's like a wandering, it might not
maybe not.
keep going away because it's going towards.
Some of it could, that's true.
It depends on where it happened.
That is true.
Different.
But it wouldn't change the,
But the morphology would change. Every
Of
P wave
course.
would have a different morphology.
absolutely.
Okay.
Would you have AFib?
AFib.
So let's come back to the junctionals for just a minute, because I'm not done with my question, because you still have refused to answer my question.
Oh,
So you might have
It's a
an
habit
inverted
we
P wave
have.
beforehand,
Uh,
you might have no P wave. What else might you see?
AFib?
You still are not answering my question. So
Will you
come
ask
back to
your,
a
will you ask
junctional
your
rhythm.
question one more time?
Say
Yeah,
the
so we're
walks
talking
are-
about junctional rhythm
Junction
in a
rhythm.
minute.
Okay.
You might have that inverted P wave
Gotcha.
beforehand,
might
you
not
might
see
have
it.
no P wave. What else might you have?
A post retrograde P wave?
How would that show up? How are some ways that that would show up?
Either
Larger
the
T-wave.
S wave, the S wave would be changed somehow, or would
How
be
would it be changed?
either depressed because, or around it. Yeah, I guess you got it.
So what would it look like?
A kind of a bulge in at the bottom of the S wave, essentially, at the height of wherever the P wave would be.
You would look like this? That's what you said, so is that what you meant?
Nope.
Okay? I mean,
At
I'm just
the-
trying to draw what you meant, so.
At the baseline, where the R wave meets the baseline, where there'd be a little bulge at the same height of what a P wave would be.
So you're saying this?
Yeah, or buried inside, slightly
then T wave?
inside. Yeah, or buried slightly inside the QRS. More.
A larger T
And
wave.
this is lead 2 for right now.
Yeah.
Why is that upright?
So that was what I was debating in my head as I was saying it would be inverted potentially. Yeah. Be inverted.
Normal QR, and you have a.
So I'm still confused by what I'm seeing, or what I'm not seeing.
You have a slur that makes it back into the baseline. So kind of sharp, and it would kind of slur back up.
Yeah, it'd be inverted.
Is that what you do?
Yeah, then with the baseline, your T wave might be buried into the S a little bit, or else if you have a little bit of an ST segment there, and you have normal T wave.
Okay. So I'll see a change in that S wave in some fashion that elongates that just a little bit. What's that a problem for sometimes?
Repolarization.
Is it a problem for repolarization?
Problem for
No.
depolarization.
What depolarization? Is it a problem for?
The ventricles again?
Why?
Because you're still in
What
absolute
what is
refractory
that-
period.
Yeah,
what
that
does
has
that
nothing
change
to do
in
with
the
it.
percent? What does that change in the S wave represent?
P wave.
The P wave.
So what does that have to do with
Atrium
atrial
dipole.
Doesn't have
What does that do with ventricular
anything to do
depolarization?
with ventricle.
So we're back to that
ventricular
same question that we had a moment ago, where we had this T wave and a P wave, right? What is this P wave doing physiologically to affect that T wave?
Nothing,
Nothing.
Nothing, it's just a fused wave,
yeah.
right? So we have, what is this P wave doing to affect that S wave? Okay, so what does it have to do with the depolarization or repolarization of the heart, of the ventricles?
Nothing.
Nothing. So what does it pose as a problem as we're analyzing this?
It's in the absolute refractory period.
We,
Is it gonna be?
From an analysis
we might think
standpoint,
it's a depressed T, like, as far as analysis, where we could get confused in something?
yes,
Like a depressed T?
or maybe it makes us think that we've got some ST depression. What else?
It looks like a bundle clock.
Which means, in order for it to look like a bone branch block, what is the defining, we haven't talked about it yet, but what's the defining characteristic?
The slurred S wave is a characteristic.
Yes? Kind of.
Why-
In
why-
some-
why
Why
QRS?
QRS?
It makes our measurement of the QRS look a little wonky. Because if we don't recognize that this junctional rhythm might have this P wave that is retrograde, right, that is happening after the
Right.
QRS, we might then mistakenly measure that QRS complex as being larger than it actually is, which might lead us down the path of believing that they have a bundle branch block or something else that they don't actually have.
But if you have a bundle branch block, you would normally have a P wave before the QRS. So if you don't have a P wave before the QRS, and you have a slurred.
Where is the bundle branch block at?
In the
Bundle
bundle
branch.
In the bundle branch.
In the
Bundle
ventricle.
branches, and where are the bundle branches
In the-
located?
in the ventricle.
In the ventricles.
So what happens, so, okay, Chandler, I have a rhythm
So they got branching off.
that has, this person is
No.
on a drug that has
Keeping
affected
me
their
honest.
SA node
Branching off.
and their atrial pathways, and have eliminated the SA node and the atrial pathways from working, okay? It has initiated a junctional rhythm, and the person happens to have a bundle branch block. What do I see?
Junctional.
See the junctional rhythm with a Y QRS.
Yes? My SA node and algorithmic cells are not working. My AV node and ventricles are working. I've initiated a junctional rhythm, and they also happen to have a bundle branch block.
So you would not have a P wave, you would have a Y
You see the
QRS.
junctional rhythm with a Y QRS?
So I wouldn't necessarily have a
No,
Q wave in that
because
situation,
the
or
bundle
at least I
branch
wouldn't have a
block
Q wave in the
would make
proper
it
place.
And I understand that, but I'm also getting at if you don't have a P wave, so
But the bundle branch
this right
block
here
is
is
a rhythm.
so
The bundle
what you
branch
just
block
stated
is
was a
making
Y
QRS
QRS
wired,
complex.
but the
We
junctional
might
is making-
mistakenly
is
see a
starting.
wide QRS complex if we don't know that there's a P wave causing that S wave.
And that's my question, so I'm thinking if you have a bundle branch block, you're gonna have an entirely wide QRS. Where if you have a
Would it be
retrograde
entirely
P
wide, or
wave,
you just have
would you
to?
normally have
The
a
S.
narrow
S wide.
QR but then a slurred S?
Depends on where the P wave falls.
Depends on what a bundle branch block is.
So it could be in the Q.
If my
Right.
bundle branch
I'm
block,
sorry, I meant that second part without.
But it
bundle
would
branch
make a
block.
QRS
I meant
wide.
that.
Depends on where the
So-
P wave falls.
So I'm trying to discern the difference between the first one you said with a, your SA and your atrial pathways are wiped out, but you have a bundle branch block, you're gonna wipe QRS.
yes,
Secondary to that, if you have a retrograde P wave with no bundle branch block, would you not, you won't see a P wave, but you'd have a narrow start to the QRS, but a
you might have that in a
slurred S?
bundle branch block too. We haven't discussed those yet, but you're gonna see lots of examples. Like a right bundle branch block is still gonna have the narrow start to the R, and it's in the S wave that it gets slurred.
Okay.
So it can be difficult to tell. The point is that that's exactly why. It's difficult to tell sometimes, and you have to, and sometimes, this retrograde P wave, I mean, if you're not thinking about it, might make you believe that it is part of the QRS, and you might then believe that they have this wide QRS that they do not have. So you have to use your investigative tools, your brain, and really look at that to go, okay, I don't think this is a wide QRS. This looks like a retrograde P wave.
And would that be every segment? Would that be every?
For as long as that problem exists, yeah. Yep, for as long as the problem exists.
Could be 1B, it could be continuous.
Yeah. Yeah. Make sense? Yes.
If this were right at the end of when that drug was canceling out the SA node and the atrial pathway, could you potentially also then have an R over that T that's gonna happen next? Because then the SA node would start again, because.
What does the SA node initiate?
That.
What does the SA node initiate? Don't look at this.
The depolarization of the
And that is represented by what on the EKG?
the P wave. So
So,
if that were your P wave.
so what was your original
Bless.
question?
If that were the P wave, and then it would go down to
I
it.
know, what was your original question? Hold on, guys, this is important. What was your original question related to what on what?
That if that were the P wave, then
Nope. I want you to say what you said. You're asking about what problem? What on top of what?
the R on top of the
Or what is the SA node what does the SA node deal with?
the atria.
And what wave? The P wave. So now go on. So how would you get an R on top of the T instead of a P?
If the P wave that were buried in the S wave.
Yep. Yep.
Then went down its normal pathway to the AV node and then triggered it, the ventricles again while they're in the refractory during the T wave. But it were past the absolute and into the refractory, or the relative refractory, could that potentially then be?
Or one
that
or
on
two.
top?
Very, very unlikely that would occur unless we're back over here to what Noah was talking about. And we'd have to completely change the repolarization process for that to occur. Because the heart is also set up so that that shouldn't happen if we're traveling down in normal pathways.
Okay.
Okay. Others? Questions at all?
So I want to talk about this one. Also, it's upside down. It doesn't really matter. Well, I guess it does matter.
There was one pack I was. Like, so literally nobody else in here.
Take a moment. And look at this. You get out a piece of paper and just jot down a couple of notes on what you think about this. Both your interpretation, what you're thinking about as you assess this patient, and what you think you should do for this patient. This is leave two unless stated otherwise.
Looks like a regular rhythm. Looks like we have an ST elevation.
PRI is normal.
Yeah.
So I'm saying sinus, normal sinus rhythm or ST elevation.
Was that a PVC?
PVC.
PVC. Does it come back into time? 2, 3.5.
Do we care about conducting or non-conducting, or
Well, you gotta name it.
compensating or non-compensating PVCs?
Well, I mean, if we want to call
It seems like it comes back approximately in time without my calipers, right?
3.5.
Yeah, and it's like 7, so. So that's a
Sinus with ST elevation.
sinus with a PV,
ST elevation with
with,
one
yeah,
port.
sinus with ST elevation with a non-conductive
Not
PVC.
compensating. is right.
Non-compensated PVC. And so what are we gonna do? We're gonna do IV, 12 lead,
Aspirin.
Phona,
and then Phona,
and then STEMI alert.
STEMI alert.
So possibly no nitro.
Possibly no
But you
nitro.
wouldn't be able to tell.
Why?
Right-sided inferior.
But doesn't necessarily mean no nitro. It means give him an IV and be ready for it to happen.
Do I happen to know this?
Possible.
Is that what you're asking? This is
Still a
me too.
little
Oh,
gray.
well, yeah, but do you got a 12 lead up on there?
I don't. This is what you have right now.
So some of them say like,
So you're saying anytime it's a lead two, you're worried about right-sided?
yeah, that's what like you kind of should check. And if it does show it, you should not.
Yeah,
That's
lead
what I
one,
asked.
lead two.
Why not give nitro?
For right-sided inferior. So this is already inferior.
Wait, just because it's inferior doesn't mean.
You don't give nitro.
No, not for
So,
inferior, that's
what are
right-sided.
your-
But that's if
what are
the
some
ST
thoughts
elevation is
here?
increasing.
Normal
from 2 to
sinus
3.
with
If it's
ST
not,
elevation and
then there's no reason to check.
non-compensated PVC.
But we can't tell.
So is that
Can you
what you
repeat
said?
that?
Sinus
Probably
rhythm
right-sided.
with ST elevation,
Probably.
non-compensated PVC.
I don't deal with probable.
That's why I said statistically.
There might be a first degree.
It's like that.
It's
So I
definitely
know
not
that
first
we
degree.
yeah.
First degree.
It's definitely not.
But the elevation's millimeter, right?
Looks like at least in the middle, yep.
Isn't there some sort of criteria for millimeters of ST elevation and contiguous leads in a 12 lead to determine that it's a
Yep.
It is. Do you know what that is?
There's
You say you
no
brought it up.
elongated.
Of course not.
Listen to Andrew, he's got a good thought here.
There's some sort of, so there's some sort of criteria that's supposed to be met for a STEMI where it's millimeters of ST elevation and it has to be in two or more contiguous leads, I think. I don't know for sure.
Potential
So
S.
well, all it means is that you have to get a 12 lead to make a definitive diagnosis for STEMI versus us.
And what does contiguous leads mean?
Contiguous leads mean,
Right next to each other.
yeah, anatomically contiguous.
I don't know what that means.
Taking pictures.
I'm dumb, so I don't know what that means.
So like
Cool, because I'm in the same boat.
on the precordial leads, like D1 and D2 are contiguous
Because why?
because the vectors that they look at are next to each other.
So they're looking at what?
They're looking at the same anatomical region of the
Okay,
heart.
so contiguous leads mean you've got two leads that are looking at the same part of the heart.
Yeah.
And what does that mean in terms of what you're seeing? It's confirming what?
It's confirming that it's not, well, two cameras see the same thing. It's not just because one camera's looking at something weird.
Good.
It's not a mechanical.
Yeah, so that's what contiguous means. So that was part one of, that was part two of what you said. Part one was millimeters of change. So what's the millimeters of change?
It's like 1 to 2 or
Isn't
something.
it like depending on what lead you're looking at?
It's something super important.
So we haven't discussed what we yet, but we
3
are.
boxes for
We will be
1
doing that
degree and 1
now.
box
We're
versus
just starting to
specific
get into
degree.
that, or we will just
Like-
start to get into that.
V1,
When you
V
talk about
leads
limb
are
leads,
like
what are the
on
limb
the
leads?
box. Limb leads.
1, 2, 3, ABL, and ABR.
Limb leads are 1, 2, 3, ABR, ABL, and ABF. Those leads, 1 millimeter change is pathologic. So a millimeter or more is pathologic. And the precordial leads, which ones are those?
The V leads.
B1
V1, V2, V3, V4, V5, and V6. It's possible to have as much as 3 millimeter change and it not be pathologic. That's a possibility. So we are looking at, that's not always the case. You can have some ST changes in the V leads that are less than 3 millimeters, but truly, you also might have a patient that has a change up to 3 millimeters and it still not be pathologic. So if the patient is symptomatic and they've got a 2 millimeter change in the V leads, we assume it's pathologic. But if we have someone that's asymptomatic and they have less than a 2 millimeter change in the V leads, they very well may not have a myocardial infarction going on or ischemia of that particular heart. 1 millimeter change is enough in a limb lead for it to be pathologic. So is this a pathologic ST elevation?
Yes.
Yeah. It is in lead 2, and since you brought it up, what other leads would I look in to help determine if this is indeed ST elevation and myocardial infarction?
Lead 3. And AVF.
What would I look?
AVR? AVR? Right side, AVR. You guys are making me question it now.
I thought it was
Maybe
AVI.
not, AVF is the foot.
AVF would be one of them. And
And
what's the
three.
other one?
Three.
Three.
And lead three. Because those three leads are what leads, what part of the heart do they look at?
Inferior.
The inferior part of the heart. If you didn't know that you needed to know this, make sure you know where the leads actually are located. When you physically put them on somebody, right? And that's something you already know.
That's crazy talk.
I know,
They
that's
don't
something
know.
you already know, and you do it all the way back in basic. You know where those leads are physically located, so you should be able to say what part of the heart they're actually looking at. Even though you have not learned what you're seeing, you have learned where you're seeing them. So make sure you pay attention to that. So, good. So what would okay, so say your rhythm again, Mark, just so that we're back on the same page and see if everyone agrees.
Sinus rhythm with ST elevation and a non-compensated PVC.
PVC, good. Do we all agree with that?
Yes.
No, did you have something to add?
I thought it might be a first degree heart block. I can't mark that out.
Is it a first degree heart block?
It definitely looks like it's longer than 3 boxes in the first label.
It's 5 boxes.
It's
Do
3.
we agree that that's the start
Yes.
of
Yeah.
my?
Yes.
Alright, anyway.
Never mind.
Yeah.
3 would be the minimum. For,
It'd be half to between this box, the big box, one big box.
Good, alright, so,
Is it compensated or not? Because it looks compensated to me. It looks like it's higher than.
well, who knows? 'Cause
Well, I don't have calipers
I
to,
know, I'm just saying.
Does it
I
matter?
don't have calipers to tell, but.
well, we do.
I like the calipers.
Let's figure it
yeah,
out.
I don't know. You'd have to have calipers. I don't have calipers with me.
So if it comes back in time, it's compensated. If it doesn't come back in time, it's not
That's
compensated.
right.
yeah, I just tried to guess it out. It didn't look like it.
Don't guess me.
No, it was my
Okay.
arm.
So, what am I thinking with this patient?
Whack me.
Bona?
What's my differential diagnosis off just the information that you have?
A potential MI, ST
So
elevation.
having an MI, right? And what are you gonna do for them in this case?
12 lead,
Okay, so we're gonna have 12 lead to find out where the MI is coming from.
IV,
What is this added concern with this particular ST elevation that I would be interested in paying attention to on my 12 lead?
If the ST elevation was increasing in lead 3 or AVF, because then it could be right-sided, so you want to check
Yeah,
that.
and specifically, which lead am I most interested in looking at in what you just said?
AVF.
3?
In lead 3, because lead 3 looks at what also?
Right side.
The right side, right? So if I see increased elevation in my lead 3 compared to my lead 2, then I don't just think inferior, but I also think
Right
right
side.
side, right? So
So-
I'll pay attention to that.
For clarification, you see an increase, i.e. you see a larger ST elevation in 3 versus 2.
I
or
see a
eight.
higher amplitude of elevation in lead 3 than lead 2, then I'm going to consider right side as being a key factor.
At what point do you withhold nitro? Because I've heard many different things from different physicians.
I'm not gonna help you with that.
Just gonna guess.
I'm not gonna. Here's the deal. Here's the deal. I can lay out a number of different positions,
Mhm.
and those physicians will have data to back them up in
Yeah.
their decisions. And some of our data has shown that giving nitro has absolutely no detrimental effect, and some believe that giving nitro does have some negative effects.
So I've, one River Bend physician said you should never do it, and the other one's like, whatever.
That's exactly right. You'll also have some that will say, you give your 3 doses and you are done. Right? So for example, you'll have some physicians that will say, this is where things are a little bit, some of the frustration that we have, right, is that we have to balance research with consensus because there isn't research, right? Please remember that not only, I just gave you that big talk about we're asking you to do the impossible, right? Not only am I asking you to do the impossible, but we've only had research to back up the different things that we're doing since 1995. Prior to 1995, all of our procedures were based on consensus. You know what consensus means?
We all agree.
Yeah, not we. We got a bunch of doctors in a room that are just going, let's do it this way. With no data to really back that up. We're now starting to get that data, but the data is a little bit convoluted because it depends on how the study was conducted, right? So you'll have some doctors, for example, some of your medical supervisors will say, you show up on scene and you had a patient who has taken 2 doses of their own nitro prior to you showing up on scene. Therefore, you have how many doses left to give? 1, and that reaches your max dose, right? You might also have a physician supervisor that says to you, they did 2 doses of nitro before you arrived on scene, and now you arrived on scene, and they say to you, how many doses have you given so far? How many doses have you given as you arrived on scene?
0.
None. So therefore, how many doses do you have to give?
3.
Right? There is some discrepancy in what that is. And there's
Just try
not,
not to piss
and
off
the
all the
reason why
ear
there's not a
doctors.
clear answer to that is because there's really not a clear answer to that. There's not a clear answer to that because we really don't have evidence to suggest one direction or the other right now. So we have to balance that a little bit. In the end, check out your patients. If the patient has given themselves 2 doses of nitro, and they're a reliable patient, and they're telling you that, yeah, my pain was excruciating before I took my nitro, and now it's a 2, right, or a 3, then you can make some decisions that, okay, their nitro helped them. I'm going to give them another dose. And if it helps them, I might even give them a dose after that. Does that exceed what their max is? Well, yeah, that exceeds what we list as what our max is, but it's not what I've given. And it's helping them. So I'm going to continue to help them. Right? That's certainly possible. Some departments have the ability, realize that though we cater a little bit to Oregon and we cater a little bit to Lane County, realize that you're becoming a paramedic in general, and you have to understand that. A lot of departments outside of the local area actually have nitro paste as well. So you'll be giving your dose of nitro and pasting them at the same time, or dripping nitro at the same time to get added amounts of nitro because it's doing its job. So there isn't a clear answer to your question. But you as a thinking EMT, you've given nitro and it helped your patient. Right? You've given nitro and it didn't help your patient. What are some decisions you'd make in those 2 situations?
Is it working or not? Is it useful or not?
Yeah, absolutely.
My question was specifically about the right-sided inferior
Yeah.
withholding.
So
and
now we
some-
get into right-sided stuff. And our concern with right-sided is what?
The
dumping of preload.
pressure would drop.
Why will it drop? Why is it gonna dump on the right side?
Because that's where your coronary arteries feed?
Say again?
Because that's where your coronary arteries are fed?
Your coronary arteries are fed on the right side?
Yeah, like when it's filling, that's through
Mm-hmm.
passive filling is when coronary, why are you mugging me? Or through passive filling is how it's.
You're making a true statement. I'm wondering how that true statement is related to the nitro though. What is
Well,
the,
if you
what's the
dump their,
concern?
if you give them something that's going to dilate those vessels.
Which
they're-
vessels?
All vessels.
Okay, great. We're gonna
And-
dilate all vessels.
And that includes coronary vessels.
True.
Then if you're filling those vessels on your, like, refill period, I'm forgetting the word for it, awesome.
Diastole.
On your, yeah, on your preload, on your, yeah, then you're not gonna have enough fluid in your system to fill that and effectively fill your atria to give you that preload.
Where is the blood that is filling those coronary vessels coming from?
The system.
Where?
Left ventricle, left aorta.
The aorta. Where is the blood that's filling the left atria? The vena cava's. You're in 2 different blood vessels.
Left,
Right.
left atria, right.
So what's our concern about right-sided MIs. Don't just tell me that it's a drop of pressure. I get that. That's our concern with nitro in general, right? But what specifically is causing our concern on the right side?
If we give nitro and the vessel dilate with that.
What vessels?
All the vessels.
The right
But which ones are we talking about as you're about to
The
talk?
vena cava.
Okay, what's gonna happen to that?
They're gonna get more blood flow, wouldn't they? And then in turn, the right atrium is gonna get more blood flow, which is gonna put more strain on it.
I used to know this. If you increase the blood flow,
Think that through for just a
Atrium.
second. I'll let you go in a minute, but think that through. You gotta think this through. So if I have, here's my blood vessel. You were talking vena cava, right?
Yeah.
Okay, so here's my vena cava.
increase the blood flow to the right atrium.
What's gonna happen? This is pre-nitro. This is pre-nitro.
It's not gonna get.
Post-nitro, what's gonna happen to the vena cava? It's going to be bigger, right? This is post-nitro. It's bigger, right? What's gonna happen to blood flow?
Increase.
The pressure goes down, but wouldn't the volume maybe go up?
The pressure
You're not-
to
you
the
don't
heart
get
will
more
go
blood.
up because
Pressure.
Because your veins are bigger.
Isn't there a pressure that it senses, and if it does, if it goes against or below the pressure, then it moves through?
We're not even that far yet. I wanna know what's happening to blood flow here.
The pressure, the blood, the pressure.
Pressure goes down.
Okay, so pressure is
Ordinary.
fine, pressure's going down because resistance is going down.
Down.
Fine. And what's happening to blood flow?
Less, with less pressure means less blood flow as well.
So what's gonna happen to my blood flow here?
Less blood flow.
Decrease.
It's gonna decrease.
Yeah,
So where is this blood, which direction is this blood supposed to be traveling?
down into the atrium or up
Depending
into
on
the
the
atrium.
Depends on, yes.
You're right, it depends on if it's inferior or superior. But how much blood flow is coming from the superior vena cava?
Very little.
Not very much.
Well, there's quite a bit, 'cause it's coming from the chest and brain and such, but from the brain, there's not a whole lot of blood flow
Right.
coming from the brain
Yeah.
compared to the bottom side. So my blood flow is gonna decrease, the flow of blood is gonna decrease, right? And not only am I getting my vena cava to dilate, but what else is dilating?
All the muscles below it,
Yeah,
all the
everything,
veins below
which
it.
means it's dilating all the way throughout my entire system, so how effectively is blood flow moving through that system? Not as good. So what is happening then to blood flow into my right atrium?
Decrease. Decrease preload.
I'm having a decreased preload.
Yeah.
I'm having a decreased preload. Okay. If I have a decreased preload into my right atrium, and decreased preload into my right ventricle, what does my body do to compensate for that?
Beat faster.
Increase heart rate.
It'll cause a reaction to my baroreflex to beat harder and to beat faster. But what's my problem?
You have,
And you don't want that.
the right side can't constrict to
Because
load
why?
that
There's no blood.
because there's a blockage.
Okay, because it's a blockage. So therefore, that's not the problem in itself. It's not just a
Yeah.
blockage, it's not constricting, it's that muscle is not working as well, right?
Right.
Okay, fine, but if that's the problem, I'm not getting Frank Starling to help me out. I've got damage to my heart, so it's not doing its contraction very well, which means the right side is not sending as much blood flow where?
To the right ventricle, to the lungs,
To the lungs, which means not as much blood flow is getting where?
To the left side.
to the left
To the
ventricle.
left side. Now, the left side is not gonna send as much blood flow into the aorta, right? That's where my baroreflex is gonna happen. That's gonna make the change in my heart, make it beat stronger and faster, right? Which is going to be positive on that left side, because the left side will beat stronger and faster, but what's the problem with that?
The
It
right
won't
side.
have the fluid in
It's still not
there.
getting the fluid. So my cardiac output still goes down, even though the left side can adequately compensate. Even though the left side can adequately compensate, it's not getting the blood flow from the right side to compensate with. Does that make sense? Change that though. Let's say we're having a left-sided MI. On the left-sided MI, my cardiac output starts to go down just a little bit because the left side is not able to eject as much blood. But what's happening to the blood flow into the left side?
It's still adequate, it's still the same.
Yeah, not only is it adequate, but the right side is gonna get its compensations to beat stronger and faster, and it's gonna continue to pile the left side with blood flow. So the left side, even though the left side's weaker, it will still move blood flow because you got a backup of blood that's forced into the left side. Frank Starling's gonna work just fine, and we are gonna have some compensation on that left side that we wouldn't have on the right side because the right side is still pushing its blood flow adequately into that left side. So my left side is still functioning better because it's got a backup of blood from that right side that's working. But my left side can't work better if the right side isn't able to do its own compensations. So our nitro has a higher effect on right-sided MIs than it does on left-sided MIs because of what's happening behind the copies.
So there's still no reason to withhold it then?
Say that again.
There's no reason to withhold nitro?
So when would we withhold versus not?
Or if you can go back to the contraindications
Got
of systolic
Fluid in their
blood
lungs.
pressure.
When would we, well, nitro would help with them ones actually. We give nitro for pulmonary edema.
Talking about the blood pressure is below 90
Yeah.
systolic.
Because if blood flow is, if our blood pressure is low, the reason that we have a problem with nitro
Mhm.
is that heart can't compensate well. We have to have control of their blood pressure really well to make sure that right side doesn't over drop the blood pressure.
So
So
for
it-
someone like this is like when I asked an ER physician, I kind of gave him like a high blood pressure with a right-sided inferior, and he said still, should have asked more, but he said don't do it, don't
Yeah,
give
and
nitro.
and that is his choice, and there are a lot of doctors that like to steer away from nitro in right-sided failures.
He said don't do it.
Yeah, there's a lot that
Should have asked more, but
You'll have other doctors that say, I don't give a crap, give it, because you're gonna control their blood pressure anyway.
But as long as they're
And all I
IV.
can tell you right now is that the jury's still out on